Thank you, Mr. Chairman. Ladies and gentlemen, dear colleagues. So this topic is usually considered for Japanese or Asian doctors because we rarely see, in particular, early gastric cancer in Western countries. And the frequent argument is that the incidence is, of course, higher, especially in Japan, but also the Japanese do screening procedures, and therefore we rarely see any case with early gastric cancer. However, as you know, there are some areas in Europe with a higher incidence, and even in the United States, I would like to show you that last year, close to 22,000 men and women were diagnosed with early gastric cancer. Half of them died. So the age-adjusted incidence rate is 7.5 per 100,000 men and women per year. So it's not a rare disease. And the current lifetime risk of those who will be born today, the risk is 0.86% of men and women to develop gastric cancer. It's higher than for esophageal cancer. So we spent many meetings on Barrett's esophagus in Western countries, but still gastric cancer is more frequent, and this we should keep in mind. And of course we detect less lesions because we don't have screening procedures and the incidence is lower, but there is no doubt that we miss lesions when we do gastroscopy. So we do millions of gastroscopy a year in Western countries, but there is no doubt that we miss these tiny lesions, and we learned this from our Japanese colleagues. So we have to look for details of just mucosal changes as shown here in the antrum. Here some irregularities of the surface at the cardia, slight elevation or slight depression here at the anterior wall of the antrum. So spend more time to detect these early lesions. And then the next step for diagnosis is to classify these lesions according to the Paris recommendations. So completely flat lesions are the best candidates for local treatment because these have a very low risk of submucosal invasion and therefore also low risk of lymph node metastasis, as well as those with a slight elevation as shown here. On the other hand, lesions with depression or combination of elevation and depression have a higher risk and incidence of submucosal invasion. So this is a very important step to identify patients who have lesions with a very low risk of lymph node metastasis for potential selection for local treatment by endoscopic resection. And then, if we consider endoscopic resection, we have to delineate the lateral lesion. This is difficult here in this projection, but you see in this completely flat lesion just a slight discoloration. And with use of NBI and magnification, here you can see the demarcation line. This is the normal gastric mucosa, and this is the cancer. And for those who have no access to these as advanced endoscopic imaging technologies, we can use a combination of chroma-endoscopy with acetic acid and indigo carmine, and now we can nicely delineate the lateral extension of this early gastric cancer. And this is a much smaller area, but a slight depression, again, magnification, NBI. We see here the irregular vascular structure and the distortion here of the mucosal pattern. And again, this is combination of acetic acid and indigo carmine. And now we can nicely delineate these small lesions, less than 1 centimeter in diameter, and this turned out to be already a cancer with submucosal invasion. So therefore, we have to identify patients with a low risk of lymph node metastasis, and according to the Japanese guideline of the Japanese Gastric Cancer Association, those are patients with mucosal adenocarcinoma, differentiated type, elevated lesions should be smaller than 2 centimeters in diameter, depressed smaller than 1 centimeter in diameter, and there should be no ulceration. The National Cancer Center in particular reported about 10 years ago on a large series on more than 5,000 gastrectomy specimens, and they analyzed the correlation between these criteria with endoscopic criteria and histological criteria and the risk of lymph node metastasis. And according to these data, the incidence is also extremely low in patients with mucosal invasion of cancer, no ulceration, independently of the lateral extension, intestinal type, and even in those with ulceration smaller than 3 centimeters in diameter and submucosal invasion, again, well differentiated, no infiltration of lymphatics and veins, low risk of lymph node metastasis. And our German Gastroenterology Society accepted these data, and these are the common recommendations now that these are potential candidates for local treatment. In all the others, surgery has to be done. However, as I've shown you, we need a precise histopathology and a complete resection of lesions. And this can be only obtained in the majority of cases, at least in those with a lateral extension of larger than 1 centimeter by endoscopic submucosal dissection. And this meta-analysis of 9 retrospective studies, there is no randomized controlled prospective trial in more than 3,500 lesions, shows the advantage of ESD compared to EMR, a 10-fold higher chance to achieve an en bloc resection, and a zero resection, the odds ratio 5.7. And another advantage of an en bloc resection and ESD is a lower recurrence rate, 90% higher chance of a complete remission and no recurrence. On the other hand, the perforation rate is higher. But in these days, we have, as we have heard from the previous speakers, we have now the tools to deal with perforation during the procedure. This is an adverse event, but no longer considered as a complication. So how to do ESD? I would like to show you one example. This is an early gastric cancer, type 2B and C, slightly depressed. Again, first step is precise delineation of the lateral margin. Then we set these coagulation markers with a safety margin of about 5 millimeters. And then the aim is to cut at the periphery of the lesion. And now this procedure is done with the so-called hybrid knife, which is a knife which allows not only cutting and coagulation, but also injection without changing the instrument. You see nicely the fluid infiltrating here the submucosa. It's mixed with saline solution, mixed with some indigo carmine, and therefore we inject, so to have a nice cushion, and then we insert the knife under the mucosa, lift the knife, and can precisely cut at the periphery of the markers. And then the next step is dissection. And as you can see, this whitish layer, this is the muscle layer, the bluish is the submucosal layer, and then we can do the submucosal endoscopy and achieve a complete resection. And the important part is also to prepare the specimen for further histopathological evaluation, so it has to be stretched on cork here with needles, and as you can see, all coagulation markers are within the specimen, and then we can expect a precise histopathology and following a discussion in the tumor board to decide if this is a curative treatment or if the patient, if these criteria which I mentioned before are not met, the patient has to undergo surgery. So, of course, the large series come from Japan, and there are many also retrospective trials. A very important study from Isomoto in more than 500 patients, close to 600 lesions, And our Japanese colleagues achieve excellent results. The curative resection rate 95%, 5-year survival rate 97%, and carcinoma-specific 100%. And interestingly, this study shows no significant difference in patients who just met the standard criteria and the extended criteria according to the National Cancer Center study. So no significant difference. And there is now a prospective controlled trial to further determine the risk in the long term of development of cancer in those with extended criteria. However, what we also learned from the Japanese is not only the technique of resection, but the close collaboration with a pathologist who provide a very detailed analysis with cut every 2 millimeters, and then they analyze the lesion in terms of differentiation, tumor size, tumor margin, vertical invasion depth, and vascular involvement. And this is an example here in a younger patient in whom we performed ESD. So again, characterization, type 2 and C, delineation with NBI magnification. We can nicely delineate the lateral margin. We set the markers, complete resection, we get the specimen, and then we wait for the histopathology. And according to German pathologists, it was a complete resection and a curative resection. But then I asked to send, because this was a signet cell carcinoma, to send the specimen to Japanese endoscopist and pathologist. And this is the detailed report we got from Japan. And in one slide, which was not seen by the German pathologist, is a lymphatic tumor cell invasion in one of the lymphatics at the level of the muscularis mucosa. So this patient finally underwent surgery. But this is a good example to show it's not only the resection, it's also the histopathology, which is extremely important. And you can imagine when you do piecemeal resection, then you may easily miss this important information. So I can refer only to a few trials from Western countries. This is the literature from studies from Europe on ESD of early gastric cancer. There is not a single trial from the United States. So we started in 2006 with poor results. Now we have become better. This was our recent publication. And as you can see, we do not achieve the high azir rates in Japan here in Western countries, but this is mainly due to unfavorable selection of patients. We have less patients with very tiny lesions who met all the standard criteria. Most of them have extended criteria, and then it's more difficult to achieve a azir resection. The procedures are quite safe, though these complications can usually be endoscopically managed. Patients may develop recurrences, they have, or metachronous lesions, of course, they have to undergo long-term follow-up, and we have to wait for long-term results. And we participate and we perform together with Professor Zhu from Shanghai the first randomized controlled trial on ESD of early gastric cancer, comparing the conventional ESD method with this water jet assisted ESD in 117 patients. We saw no significant difference in terms of en bloc and azir resection rate, which were quite high. Most of these patients came, as you can expect, from Shanghai because of the high incidence of cancer. Safe, these perforations could be endoscopically managed. However, the water jet assisted technique was significantly faster because we need less frequently changes of the accessories. So I would like to conclude. Everybody should really take more time in doing gastroscopy, careful inspection as you do now for colonoscopy for increasing the detection of adenomas, for finding these early gastric neoplastic lesions. And patients who meet the standard criteria do not require major surgery but can undergo endoscopic resection. Those with expanded criteria should be considered for endotherapy, decision-making, and tumor boards. and requirements for endoscopic resection. You should have enough expertise in ESD, which should achieve en bloc resection. We need, as I've showed you, detailed histopathology and a careful follow-up. Thank you very much for your kind attention.
Thanks a lot, Prof.